Respected Emeritus Chairperson, Mahatma Gandhi Medical College, Mahatma Gandhi University of Medical Sciences and Technology, respected Chairperson Dr. Vikas Swankar, Vice Chancellor Dr. Achal Gulati, Pro Vice Chancellor Dr. V.K. Kapoor, Principal Mahatma Gandhi Medical College and Hospital Dr. N.D. Soni, respected senior faculty members, colleagues, and dear students. On behalf of Mahatma Gandhi Medical College and Hospital, Core Group UGCR, I extend warm welcome to you all. Today we are conducting our 7th UGCR. The topic for this is diabetes mellitus. And we have divided it into 2 parts. Part 1, which is being presented today, would consist of anatomy, physiology, biochemistry, and pathology related to diabetes mellitus. And part 2 would be consisting of clinical aspects, pharmacological aspects, and preventive aspects of diabetes mellitus. Today's our subject expert is Dr. RajeevKasliwal, who is professor in Endocrinology Department, Mahatma Gandhi Medical College, and the session would be chaired by Dr. S.K. Sharma, who is professor and head of Department of Endocrinology, Mahatma Gandhi Medical College, Sitapura, and Dr. Kishore Mool-Rajani, who is senior professor in the Department of General Medicine, Mahatma Gandhi Medical College. Now I would invite our subject expert, Dr. RajeevKasliwal, to give introduction of diabetes mellitus and followed by the presentation by our students. Dr. RajeevKasliwal.
Good evening, good morning, everyone. So today we are going to deal with probably one of the most important topic of medical science right now we are dealing with is diabetes mellitus. And I think if I ask everybody that whether one of your family member is suffering from diabetes or not, I am expecting that most of you are going to raise your hand. So that is kind of situation which we are facing. It's going to be an epidemic and very epidemic with very severe consequences, because diabetes is not just a single disease. Diabetes is a kind of you can say mother of all diseases, especially all non-communicable diseases what we are talking about. So it does not come it does not come alone, but it will bring several other problems also. And the cost of treating those the disease per se and their complications are very huge, which a country like India, who is still in developing phase and not so strong in terms of resources, we are going to face severe challenges, and we are going to pay the price if we do not take corrective action in timely manner. If I can tell you about the prevalence of diabetes right now, what we are seeing is like almost 11 to 12%. Right now we have in India almost 100 millions diabetic. We were supposed to reach that number in 2030, but we have reached that number in 2023 only. So all the projections are actually going wrong, and in fact we are traveling in a direction where the future looks very bleak in terms of diabetes prevention comes. And one of the important contributor to the diabetes is another epidemic which we are facing is the obesity, which is worsening or adding fuel to the fire kind of a thing that is happening and leading to more and more diabetes. Diabetes overall is a situation where it's when we simplify the pathology, it's a state of increased blood sugars, either because of decreased secretion of insulin from pancreas or decreased insulin action leading to ineffective glucose disposal in the blood circulation, which ultimately affects all the major organs of the body. It leads to multiple macrovascular complications and multiple microvascular complications. If we talk about today, diabetes is the most common cause of adult onset blindness, Diabetes is the most common cause of, diabetic or the CKD. Almost 40% of the CKD currently is happening because of diabetes and leading to, transplant or lifelong dialysis. If we talk about nowadays, we are, hearing more and more new entity, fatty liver or NASH, more and more number, almost 60% or 70%, depending on study to study, anywhere from 40 to 60% patients of diabetes are having NASH, NAFLD. Some of them have NASH and ultimately land up in cirrhosis also. So you take any multiple complications, all behind all of them, the central figure is uncontrolled blood sugars. And so it is our duty as a medical fraternity that if, no matter which branch we are, we practice, or we practice as a clinician or physician, or as a subject specialist in particular super specialty, we all need to know what is the diabetes and how to treat it, because probably all of us are going to face a situation where we will encounter with this question, that how to treat our family members or nears and dears ones and diabetes, whether they are doing fine or not. So this session is being arranged keeping this in mind, and it is going to cover etiology, pathology, biochemistry, biochemical diagnosis of diabetes, and then how do we treat the general principle of treatment of diabetes. That is what we're going to be covered in it. And I hope you will gain tremendous knowledge about this disease, because whether you like it or you don't like it, it is going to come into your life one way or other way, that we need to face and accept it. Thank you.
Good afternoon, esteemed dignitaries, faculty members, and my fellow colleagues. Today, I, Shubhi Shrivastava, along with my team members, Adhar Sharma, Aman Singh, Ananya Tank, and Somal Chaudhary, are here to present on the topic Anatomy of Pancreas. This presentation was made under the guidance of Dr. J.M. Sharma Sir, Professor and Head of Department of Anatomy, with the moderatorship of Dr. Rati Tandon Ma'am, Associate Professor, Department of Anatomy, and Dr. Manali Arora Ma'am, Associate Professor, Department of Anatomy. The contents of this presentation include the development of pancreas and its anomalies, gross anatomy of pancreas, microanatomy of pancreas, and the applied aspects of the pancreas. The pancreas develops from the two endodermal buds, that are the ventral pancreatic bud and the dorsal pancreatic bud. The ventral pancreatic bud develops from the ventral wall of the caudal part of the foregut, while the dorsal pancreatic bud forms from the dorsal wall of the caudal part of the foregut. The dorsal pancreatic bud appears first and is larger in comparison to the ventral pancreatic bud. As shown in the diagram, first the duodenum rotates to the right and becomes C-shaped. Then the ventral bud moves dorsally to lie below and behind the dorsal bud. Finally, both the bud fuses around 7th week of intrauterine life to lie in the mesentery. The ventral pancreatic bud forms the inferior part of head and the uncinate process, while the dorsal pancreatic bud forms the upper part of head, neck, body, and the tail of pancreas. There are two major pancreatic ducts. First, the main pancreatic duct of Wirsing, which develops from the distal 3/4 of the dorsal pancreatic duct, anastomosis between the dorsal and the ventral pancreatic duct, and the proximal 1/4 of the ventral pancreatic duct. Secondly, the accessory pancreatic duct of Santorini, which develops from the proximal 1/4 of the dorsal pancreatic duct. The acini and islets of Langerhans of pancreas develops from the enormous branching of both the dorsal and the ventral pancreatic bud. The serous acini appear at the terminal branch of each bud, while some cells undergo differentiation to form the islets of Langerhans around 3rd week of intrauterine life, and they start secreting insulin by the 10th week of intrauterine life. There are three major developmental anomalies of pancreas. First, the annular pancreas, which is due to failure of rotation of the ventral pancreatic bud. It generally encircles the duodenum, which can cause the duodenal obstruction. Secondly, the accessory pancreatic tissue, which means there is ectopic pancreatic tissue present in the abdomen, like in the wall of duodenum, jejunum, ileum, or in the wall of Meckel's diverticulum. Lastly, the inversion of pancreatic duct. Here, the accessory duct becomes larger than the main duct, and the main drainage of pancreas is by the accessory duct via the minor duodenal papilla. Pancreas is a soft lobulated gland that is partly endocrine and partly exocrine. It is a J-shaped or retort-shaped organ that lies transversely on the posterior abdominal wall, extending from the 12th thoracic vertebrae to the 3rd lumbar vertebrae. Pancreas is divided into 4 parts: head, having a process known as uncinate process; neck, which is a slightly constricted part; body, having a process known as tuberomental; and the tail that lies in the hilum of the spleen. The head of pancreas have 3 borders and 2 surfaces. The 3 borders are superior border, right lateral border, and the inferior border, while the 2 surfaces are anterior surface and the posterior surface. The first part of duodenum and superior pancreatico-duodenal artery lies superiorly to it, while the second part of duodenum and the terminal part of bile duct lies laterally to it. Finally, the third part of duodenum and the inferior pancreatico-duodenal artery lies inferiorly to it. The structures present anteriorly to the head are the first part of duodenum, transverse mesocolon, transverse colon, and the jejunum, while the structures present posteriorly to the head are the bile duct, the inferior vena cava, the terminal parts of renal veins, and the right crus of diaphragm. The neck of pancreas have 2 surfaces, the anterior surface and the posterior surface. The anterior surface is related to the lesser sac and the pyloric end of stomach, while there is formation of portal vein posteriorly to the neck at level of 2nd lumbar vertebrae. That means the posterior surface is related to the terminal part of superior mesenteric vein, while the beginning part of the portal vein. The body of pancreas have 2 borders and 2 surfaces. The 2 borders are superior border and the inferior border, while the 2 surfaces are anterior surface and the posterior surface. The structures present superiorly to it are the celiac trunk over tuberomental, splenic artery, and the hepatic artery, while the structures present inferiorly to it are the superior mesenteric vessels. The structures present anteriorly to the body are transverse mesocolon, duodenojejunal flexure, coils of jejunum, and the left colic flexure. The structures present posteriorly to the body are the aorta with origin of superior mesenteric artery, the splenic vein, the left suprarenal gland, left kidney, left renal vessels, and the left crus of diaphragm. The tail of pancreas lies in the linorenal ligament. It is related to the visceral surface of the spleen. There are 2 major pancreatic ducts. First, the main pancreatic duct of Wirsing, which opens in the second part of duodenum at the major duodenal papilla that lies 6 to 8 cm distal to the pylorus. Secondly, the accessory pancreatic duct of Santorini, which opens in the minor duodenal papilla that lies 6 to 8 cm distal to the pylorus, while the major duodenal papilla lies 8 to 10 cm distal to the pylorus. The main pancreatic duct receives many small tributaries at acute angles to it, forming the herringbone pattern. The pancreas and the duodenum forms at the junction of foregut and the midgut. So, they are supplied by the arteries supplying foregut and the midgut, that are the celiac trunk and the superior mesenteric vessels. The pancreas is mainly supplied by the pancreatic branches of the splenic artery, while some minor chunk is also supplied by the superior and inferior pancreaticoduodenal arteries. The venous drainage of pancreas consists of the major three veins, that are the portal vein, the superior mesenteric vein, and the splenic vein. The lymphatics from pancreas drains into four major lymph nodes, that are the pancreaticosplenic lymph nodes, celiac lymph nodes, superior mesenteric lymph nodes, and the pyloric lymph nodes. The nerve supply of pancreas consists of mainly two fibers, that are the sympathetic fibers and the parasympathetic fibers. The sympathetic fibers are derived from the splanchnic nerves that have a predominantly inhibitory effect on the pancreas, while the parasympathetic fibers are derived from the vagus nerve. They have a stimulatory effect on both the exocrine and the endocrine part of pancreas. As we know, the pancreas is a partly endocrine and partly exocrine gland. So, the microanatomy of the endocrine and the exocrine part varies. The exocrine part consists of the serous acini and the ductal system, while the endocrine part consists of the islets of Langerhans. Islets of Langerhans are most abundant in the tail of pancreas, and they consist of alpha cells, beta cells, delta cells, G cells, and the PP cells. The beta cells are highly glandular and basic in nature. They constitute around 70 to 80% of the cell population, and they mainly secrete insulin. The alpha cells are also highly glandular but are acidic in nature. They constitute around 15 to 20% of the cell population. They are further subdivided into two types, the A1 cells and the A2 cells. The A1 cells belongs to the enterochromaffin group of cells and secrete serotonin, while the A2 cells secrete glucagon. The delta cells constitute around 5 to 10% of the islet cells, and they mainly secrete somatostatin. The G cells constitute around 1% of the islet cells, and they mainly secrete gastrin. Finally, the PP cells, or the pancreatic polypeptide cells, they constitute around 1% of the cell population, and they mainly secrete pancreatic polypeptides. The exocrine part of pancreas consists of the pancreatic acini or the serous acini and the ductal system. The serous acini are lined by the pyramidal cells with basal round nuclei containing the zymogen granules. It mainly secretes pancreatic digestive juice. The ductal system consists of the centroacinar cells, intercalated ducts, interlobular ducts, intralobular ducts, and the main pancreatic duct. There are three major diseases associated with the pancreas. Firstly, the diabetes mellitus, which affects the islets of Langerhans of pancreas. It is mainly divided into two types, that are the type 1 and the type 2. Type 1 is insulin dependent or autoimmune in nature, while the type 2 is non-insulin dependent in nature. Secondly, the acute pancreatitis, which is the acute inflammation of the pancreas due to obstruction of pancreas or trauma to pancreas, or maybe some viral infections like mumps or acute alcohol ingestion. Finally, the carcinoma of head of pancreas, which generally compresses the bile ducts, causing the persistent obstructive jaundice. Now, I pass on the mic to my colleague representing the Department of Physiology. Thank you.
Good afternoon, Excellencies, respected faculty members, and my fellow colleagues. I, Rakshit, along with the help of my team members, Gargi Gautam, Gaurav Soni, Mansi Mishra, and Prachi Bansal, am here to present on the topic regulation of blood glucose. This presentation was formed under the guidance of Dr. Aparna Garg, Professor and Head, Department of Physiology, and under the moderatorship of Dr. Manish Lamoria and Dr. Premchand Lamba. At the end of this presentation, you will be able to appreciate digestion and absorption of carbohydrates, glucose transporters and their site of expression, hepatic regulation of glucose, serum glucose levels and factors affecting them, hypoglycemia and hyperglycemia, structure, synthesis, and mechanism of action of insulin and glucagon, and cellular uptake of glucose. Glucose, as we all know, is the most important source of energy for all organisms. Chemically, it is a 6-carbon polyhydroxyaldehyde. But this leads to a question. Where does this glucose come from? Well, carbohydrates form a major significant fraction of our dietary calories. The principal dietary carbohydrates are polysaccharides like starches and their derivatives, disaccharides like lactose and sucrose, along with the monosaccharides like fructose and glucose. After ingestion, their principal site of digestion are mouth and intestinal lumen, where they are broken down into their constituent monosaccharides and absorbed through the enterocytes. Let's see how. Here we can see the sodium-dependent glucose absorption through SGLT transporters in enterocytes on your left-hand side and renal tubular cells on the right. Now let us understand a bit about these transporters. Glucose cannot diffuse directly into the cells but enters by one of the two transport systems, that is a sodium and ATP dependent co-transport system or a sodium and ATP independent transport system. Let us first talk about the members of active transporters, that is sodium glucose luminal co-transporter 1 and 2. SGLT1 is primarily responsible for uptake of glucose from intestine, whereas SGLT2 is responsible for glucose transport out of the renal tubules in an energy-dependent fashion. Now coming over to the passive system, which is mediated by a family of 14 glucose transporter isoforms found in the cell membranes and expressed in a tissue-specific pattern. But we will focus on some significant ones only. Glucose luminal uptake transporter or GLUT1 and 3 are involved in the basal uptake of glucose, that is insulin-independent glucose uptake, whereas GLUT2 is present in the beta cells of the pancreas and acts as a glucose sensor for insulin release. GLUT4 is abundant in muscles and adipose tissue and responsible for insulin-dependent glucose uptake. So insulin-sensitive tissues taking up glucose via active transport are choroid plexus, renal tubules, and interstitial epithelium, whereas those taking up glucose via facilitated transport are brain, liver, cornea, lens of the eye, leukocytes, and erythrocytes. On the other hand, insulin-sensitive tissues are skeletal muscle, cardiac muscle, and adipose tissue. Here we can see this graph shows the relationship between filtered load of glucose, tubular transport maximum for glucose, and rate of glucose loss in the urine on the y-axis and plasma concentration of glucose on x-axis. Here, the filtered load is shown by the red line. The transport maximum, which is 375 mg per minute, is represented by the blue line, and the appearance of glucose in urine, which begins at the concentration of 180 mg per deciliter, is indicated by the green line, and it is known as the renal threshold for glucose. Liver plays a significant role in maintaining the stability of blood glucose levels by removing excess glucose from the blood and returning it as needed, the so-called glucose buffer action of the liver. The glucose in serum meets its fate by either being utilized by the peripheral tissues to produce ATP or stored as glycogen or triglycerides. When the serum glucose level falls, the glucose is reverted to the blood by either breaking down of the glycogen or de novo synthesis of glucose from amino acids, lactate, and glycerol via gluconeogenesis. This process is strictly regulated by various hormones that we shall see shortly. Now, first have a look at the normal serum glucose levels. According to the American Diabetic Association, the fasting blood glucose is 70 to 100 mg per deciliter. Postprandial blood glucose is less than 140 mg per deciliter, and glycosylated hemoglobin, that is HbA1c, is to be less than or equal to 5.6%. There is a constant tug of war between insulin on one hand and glucagon, epinephrine, corticosteroids, growth hormone, thyroxine, etc. on the other. Insulin decreases glycogenolysis, gluconeogenesis, ketogenesis, and lipolysis, whereas on the other hand, glucagon and the group of hormones increases glycogenolysis, gluconeogenesis, ketogenesis, and lipolysis. Albeit all of them are constantly trying to keep glucose levels within the normal physiological range, but at times there is some derangement in these processes, leading to two conditions, either hypoglycemia or hyperglycemia. Hypoglycemia is characterized by blood glucose level less than 50 mg per deciliter, but as the serum glucose level falls, two overlapping glucose regulatory systems are activated. The pancreatic cell releases glucagon and simultaneously the production of insulin is decreased, following which the receptors in hypothalamus get activated and respond to the abnormally low concentration of glucose by increasing the secretion of ACTH, cortisol, epinephrine, and norepinephrine. Together, these increase the blood glucose by promoting gluconeogenesis and glycogenolysis. Now let us see how glucagon brings about these metabolic effects. Glucagon, which is an amino acid peptide, is synthesized by the alpha cell in the islet of Langerhans. The gene for glucagon is located on chromosome 2 and it gets transcribed to mRNA, which is further translated to proglucagon in rough endoplasmic reticulum. The protease in the alpha cell subsequently cleave it into mature glucagon molecule and several other biologically active peptides. After getting released, glucagon binds to high affinity G protein coupled receptors on the cell membranes. It causes a rise in cyclic AMP, which in turn activates cyclic AMP dependent protein kinase A and increases the phosphorylation of specific enzymes, which can cause either activation or deactivation of the key regulatory enzymes involved in the carbohydrate and lipid metabolism, ultimately leading to the rise in serum glucose levels. Another state opposite to this is hyperglycemia, which can be caused by either consuming carbohydrate-rich diet or impaired glucostatic function of the liver or due to the impaired insulin secretion. In either case, increased serum glucose leads to glycosuria, osmotic diuresis, electrolyte depletion, which further leads to dehydration and acidosis, and if untreated, finally leading to coma and death. Coming over to the insulin, which is an amino acid peptide synthesized by the beta cell in the islet of Langerhans. The gene for the insulin is located on the short arm of chromosome 11 that is transcribed to mRNA, which move to cytoplasm and get translated to pre-pro-insulin. The signal sequence is cleaved and pro-insulin is formed in the lumen of rough endoplasmic reticulum. That pro-insulin is transported to Golgi apparatus where it is cleaved into insulin and C-peptide or connecting peptide. And they are then released in equipolar amounts from the beta cell. The C-peptide has a diagnostic importance as its level in the blood provides an index of the beta cell function, the details of which will be covered by the Department of Biochemistry. Moving on to the mechanism of insulin secretion. So far, we have understood that glucose is the primary stimulus for the insulin secretion. It enters the beta cell via facilitated transport through GLUT2 receptors. And once inside the cell, the glucose is converted to glucose 6-phosphate by the enzyme glucokinase. Its further metabolism leads to the production of ATP, and it causes the closure of ATP-sensitive potassium channels, leading to the depolarization of the cell, which further leads to opening of voltage-gated calcium channel and influx of calcium. Insulin is released from the secretory granules via calcium-mediated exocytosis, and once released, insulin binds to the specific high-affinity receptors present in the cell membrane of the insulin-sensitive tissue that we have discussed in the beginning. Insulin receptor is made of two subunits, alpha subunit and beta subunit. Alpha subunit binds the insulin and intermembrane beta subunit has a tyrosine kinase activity, which phosphorylates the tyrosine in an insulin receptor substrates and promotes the activation of protein kinases and phosphatase, which brings about the metabolic effect of insulin. Now let us have a look at how glucose enters the cell. When insulin binds to its receptor in the cell membrane, this leads to a signaling cascade that promotes the recruitment of glucose transporters from intracellular pools. The glucose transporter, that is the GLUT4, increases the insulin-mediated uptake of glucose in the cell, and when the insulin level decreases, the GLUT4 moves back into the cell membrane into the intracellular storage pool where it can be recycled. Now once again have a look at the most significant part of the today's presentation, the glucose transporters. If we put it simply, there are two types, energy-dependent glucose transporters and energy-independent glucose transporters. SGLT1 and 2 are sodium and ATP-dependent transport systems in the interstitial enterocyte and renal tubular cells respectively, responsible for absorption of glucose. Energy-independent transport systems are further of two types, either insulin-sensitive or insulin-insensitive. The GLUT1 and 3 are responsible for basal uptake of glucose in insulin-independent fashion. GLUT2 is a glucose sensor, is also insulin-insensitive. And most important of all, GLUT4 is responsible for insulin-mediated glucose uptake in the muscle and adipose tissues. So in the nutshell, this can be concluded that there is a fine regulation between the states of hypoglycemia and hyperglycemia and normal serum levels somewhere in between. Now, we have understood that the blood glucose levels decreases due to cellular uptake of glucose, glycogen synthesis, lipogenesis, and due to the action of hypoglycemic hormones such as insulin. We can also confidently say that the blood glucose levels increases due to absorption of glucose, glycogenolysis, gluconeogenesis, or the action of hypoglycemic hormones such as glucagon, cortisol, epinephrine, thyroxine, growth hormone, etc. So this knowledge will be significant for the understanding of diabetes mellitus, which will be covered by the forthcoming departments. Now I would like to call upon my colleague representing the Department of Pathology. Thank you.
A very good afternoon to all the respected dignitaries, faculty members, and my fellow colleagues. Today I, SonalAgarwal, along with my teammates Sara Sadat, Ayushi Sharma, Pragya Gupta, and Nancy Ojha of Batch 2021 have prepared a presentation on the topic Etiology and Pathogenesis of Diabetes under the guidance of Dr. Manju Raghav ma'am and moderatorship of Dr. Soni Mandal ma'am. Diabetes mellitus comprises a group of metabolic disorders that share the common features of hyperglycemia. Hyperglycemia in diabetes results from defects in insulin secretion, insulin action, or most commonly both. Major risk factors for the type 1 diabetes mellitus are family history, age, and race. And for the type 2 diabetes mellitus, it involves previous identification of prediabetes, obesity, age, race, family history, habitual physical inactivity, and women with gestational diabetes. According to American Diabetes Association 2021, the etiological classification of diabetes mellitus includes type 1 diabetes mellitus, type 2 diabetes mellitus, gestational diabetes mellitus, and specific types due to other causes. It is divided into further subtypes that are genetic defects of beta cell function, genetic defects in insulin action, immune-mediated diabetes, exocrine pancreatic defects, endocrinopathies, infections, drugs and chemical-induced, and genetic syndromes associated with diabetes. Now elaborating these special types in more details. First, genetic defects of beta cell function. Maturity onset diabetes of young caused by mutations in hepatocyte nuclear factor 4 alpha, glucokinase, hepatocyte nuclear factor 1 alpha. Second, genetic defects in insulin action includes type A insulin resistance, lipoatrophic diabetes. Uncommon forms of immune-mediated diabetes mellitus include stiff man syndrome, anti-insulin receptor antibodies. Endocrine pancreatic defects involves chronic pancreatitis, pancreatic cancer, cystic fibrosis, hemochromatosis. Other causes of diabetes mellitus are endocrinopathies that includes acromegaly, Cushing syndrome, hyperthyroidism, pheochromocytoma, infections caused by cytomegalovirus, Coxsackie B virus, congenital rubella. Drugs and chemicals also induces diabetes mellitus that includes glucocorticoids, thiazides, beta blockers, phenytoin. And genetic syndromes associated with diabetes includes Down syndrome, Klinefelter syndrome, Turner syndrome, and Prader-Willi syndrome. Now coming to the pathogenesis of type 1 diabetes mellitus, it includes genetic susceptibility, environmental factors, and beta cell destruction. First, genetic susceptibility. HLA gene cluster contributes as much as 50% of genetic susceptibility. CTLA4 and PTPN22 have been linked with the type 1 diabetes mellitus. 90 to 95% of Caucasians with this disease have HLA-DR3 or HLA-DR4 haplotypes. Environmental factors. Viral infections can also act as a trigger. Virus might share epitopes with the islet antigens, and immune responses to the virus results in cross-reactivity and destruction of islet tissues. Third, mechanism of beta cell destruction. The fundamental immune abnormality in type 1 diabetes is a failure of cell tolerance in T cells specific for islet antigens, can happen in form of defective clonal deletion of self-reactive T cells, defects in function of regulatory T cells, and abnormal resistance of effector T cells to suppression by regulatory cells. These autoreactive T cells that survive causes the initial immune responses in peripancreatic lymph nodes. These activated T cells then go to the pancreas and attack beta cells, leading to its injury. Coming to the pathogenesis of type 2 diabetes mellitus, it includes genetic factors, environmental factors, and metabolic defects. First, genetic factors. This is evidenced by the disease concordance rate of greater than 90% in monozygotic twins, a rate higher than in type 1 diabetes mellitus. Many of the genes involved are in adipose tissue function, islet beta cell function, and obesity. Second, environmental factors. The most important risk factor for the type 2 diabetes mellitus is obesity, particularly central obesity. Even modest weight loss through dietary modifications can reduce insulin resistance and improve glucose tolerance. Sleep disorders like obstructive sleep apnea and circadian disruptions seen in shift workers and people with sleep disorders are the other environmental risk factors. Third, metabolic defects. That includes insulin resistance and beta cell dysfunction. Insulin resistance is decreased response of peripheral tissue to insulin, especially by skeletal muscle, adipose tissue, and liver. Obesity is the most important factor that contributes to the insulin resistance. This figure shows the development of type 2 diabetes mellitus. Central obesity is more lipolytic than peripheral obesity that leads to the release of adipokines, free fatty acids, and cause chronic inflammation that ultimately leads to insulin resistance. Due to insulin resistance, these pancreatic beta cells secrete insulin in excess amount to compensate it. But over time, beta cells are unable to compensate the increasing secretory needs to maintain the euglycemic state, which leads to the beta cell failure and decreased insulin resistance, leading to frank diabetic state where permanent insulin depletion occurs. Now let's see the downstream effects of insulin resistance on our body. First, failure to inhibit endogenous gluconeogenesis in liver leads to high fasting blood sugar levels. Failure of glucose uptake and glycogen synthesis in skeletal muscle causes the high postprandial blood glucose levels, and failure to inhibit activation of lipases in adipose tissue leads to high level of free fatty acids in our body. Beta cell dysfunction. Beta cell dysfunction is due to the inadequate insulin secretion in the face of insulin resistance and hyperglycemia. Mechanisms promoting beta cell dysfunction in type 2 diabetes are excess free fatty acids, impact of chronic hyperglycemia, abnormal incretin effects leading to the reduced secretion of gastric inhibitory polypeptide and glucagon-like peptide 1, amyloid deposition within the islets. Now just touching the gestation diabetes mellitus, when women who were previously euglycemic develops impaired glucose tolerance and diabetes for the first time during their pregnancy is known as gestational diabetes. Pregnancy is a diabetogenic state in which the prevailing hormone milieu favors insulin resistance. Poorly controlled diabetes that arises later in pregnancy, regardless of the prior history, can lead to the excessive birth weight in the newborns. It may have long-term sequelae for the child later in life, including an increased risk of obesity and diabetes. Morphological lesions that are seen in pancreas are inconstant and rarely of diagnostic value. In the type 1 diabetes mellitus, there is reduction in number and the size of islets. Insulitis is a morphological lesion that is typically seen more in type 1 diabetes. As we can see clearly in this picture, there is infiltration of mononuclear cells, that is lymphocytes and macrophages in islets, leading to its destruction. In the type 2 diabetes mellitus, amyloid replacement of islets is mainly seen in long-standing type 2 diabetes that appears as pink and amorphous deposition. At the advanced stages, these fibrosis can also be observed. Chronic complications of diabetes. In central nervous system, it causes microangiopathy, cerebral vascular infarcts, and hemorrhage. In the eyes, it causes retinopathy, cataract, and glaucoma. In blood vessels, it causes hypertension and atherosclerosis. In heart, it causes myocardial infarction. In kidney, it causes nephrosclerosis, glomerulosclerosis, and renal arteriosclerosis. In the peripheral organs, due to peripheral vascular atherosclerosis, it leads to gangrene and infections. Pathogenesis of these will be explained in upcoming slides. Diabetes mellitus is a condition of persistent hyperglycemia that causes the formation of advanced glycation end products. These advanced glycation end products bind with their specific receptors that are RAGE are expressed on the inflammatory cells, endothelium, and vascular smooth muscles. They causes the release of cytokines and growth factors that includes transforming growth factor beta, This is responsible for the excess basement membrane material that leads to diabetic neuropathy and retinopathy. Also, vascular endothelial growth factors are implicated in diabetic microangiopathy. They also cause the generation of reactive oxygen species in endothelial cells, enhanced proliferation of vascular smooth muscle cells, and increased procoagulant activity on endothelial cells and macrophages. Persistent hyperglycemia also causes the activation of protein kinase C that leads to the production of VEGF, TGF-beta, and plasminogen activator inhibitor 1 by vascular endothelium that leads to the diabetic microangiopathy. Oxidative stress and disturbances in polyol pathways causes sorbitol accumulation in lens, leading to cataract formation. Sorbitol also causes the depletion of intracellular NADPH by aldolase reductase that decreases the reduced glutathione regeneration, leading to oxidative stress ultimately. Hexosamine pathways and generation of fructose 6-phosphate leads to cellular damage and oxidative stress. Chronic complications are broadly divided into macrovascular disease, in which large and medium-sized muscular arteries are affected, and microvascular disease, in which small arteries are affected. Individuals with diabetes are at high risk of developing macrovascular complications like coronary artery disease leading to myocardial infarction, cerebrovascular disease leading to stroke, and peripheral artery disease causing gangrene of lower extremities. The hallmark of diabetic macrovascular disease is accelerated atherosclerosis. Atherosclerosis refers to the building up of plaque in arteries, leading to narrowing and hardening of blood vessels. When this occurs in individuals with diabetes, it's often referred to as diabetic macrovascular disease. Diabetes accumulates the development and progression of atherosclerosis due to factors like chronic blood sugar levels, abnormal lipid metabolism, and inflammation. This cross-section of artery wall depicts the atheromatous plaque. On zooming the affected layer, that is tunica intima, the plaque consists of fibrinous cap that comprises of smooth muscle cells, macrophages, and foam cells. Beneath it, there is a necrotic center which shows that cellular debris, cholesterol crystals, foam cells with cholesterol droplets. Above the fibrous cap, there is regenerating endothelium layer present. The complications of diabetic microangiopathy involves diabetic neuropathy, retinopathy, and nephropathy. Diabetic neuropathy is a common complication of diabetes affecting nerves throughout the body, leading to sensory, motor, and autonomic nerve dysfunction. This results in symptoms like numbness, tingling, muscle weakness, impaired sensation, and organ dysfunction. Diabetic retinopathy is a serious complication that affects eyes. High blood sugar damages retinal blood vessels, causing leakage and abnormal growth. This leads to renal ischemia, retinal ischemia, inflammation, and eventually leads to vision loss. Diabetic nephropathy. Diabetic nephropathy is a serious kidney complication of diabetes. Prolonged high blood sugar levels causes damage to small blood vessels of kidney. This leads to inflammation, oxidative stress, scarring, and various lesions of kidney tissues that impair its function over time, ultimately leading to end-stage renal disease and renal failure. Now elaborating its lesions, first glomerular lesion. It comprises of capillary basement membrane thickening, diffuse mesangial sclerosis, and nodular glomerulosclerosis. The capillary basement membrane thickening occurs virtually in all cases of diabetic nephropathy and is best appreciated by electron microscopy, as can be visualized here. The same thing can be appreciated in this past-end histological section where these pink bands shows the thickened basement membrane. Diffuse mesangial sclerosis. These lesions consist of diffuse increase in mesangial matrix. These depositions are PAS positive. On progression, these depositions can take form of nodular appearances at the periphery. Nodular glomerulosclerosis. It is also known as Kimmelstein-Wilson disease. The nodular sclerosis that we saw in the previous slide are frequently accompanied by the prominent accumulation of hyaline material. When this hyaline material accumulates in the capillary loops, forms a fibrin cap, and when it adheres to the Bowman's capsule, forms a capsular drop. Renal vascular lesion. Hyaline arteriosclerosis affects both efferent and efferent arterioles. This picture shows the hyaline deposition in the arteriolar wall. pyelonephritis. It comprises of acute and chronic forms, and both are common. The gross feature of acute pyelonephritis shows the grayish yellow areas of inflammation and abscess formation on its surface. Here, in this microscopic figure, there is neutrophilic infiltration in its tubule and inflammation in its interstitium. The gross features of chronic pyelonephritis shows contraction of kidney, showing unequal reduction in size, irregular scarring on its surfaces, dilated pelvises, and blunt calyces are seen. In its histological feature, it shows inflammatory infiltrates of mononuclear cells that are lymphocytes and macrophages in its interstitium, and there is also varying degree of atrophy and thyroidization in its tubules. Now, I would like to conclude by summarizing the major differences between type 1 and type 2 diabetes mellitus. On the basis of genetics, there is major linkage to MHC class 2 genes in the type 1, whereas there is no HLA linkage in type 2. On the basis of pathogenesis, there is dysfunction in T cell selection and regulation leading to breakdown in cell tolerance to islet autoantigens in type 1, whereas in type 2, insulin resistance in peripheral tissues, failure of compensation by beta cells. On the basis of pathology, in type 1, there is insulitis, beta cell depletion, and islet atrophy, whereas in type 2, there is no insulitis, amyloid deposition in islets, and mild beta cell depletion is seen. Now, I would like to call Shruti from the Biochemistry department to continue further. Thank you.
Good afternoon to all the dignitaries, faculties, and my fellow colleagues present here. Myself, Shruti Pungliya, with the help of my batchmate, Khushi Sharma, Pratik Mundra, Pratham Solanki, Shivangi Sharma, have made this presentation on topic biochemical investigation of diabetes under the guidance of Dr. G.S. Gupta sir, Professor and Head of Biochemistry Department, and Dr. Bushra Fiza ma'am, Professor of Department of Biochemistry, under the moderatorship of Dr. Arun Kumar sir, Associate Professor of Department of Biochemistry, and Dr. Jaskiran Kaur ma'am, Assistant Professor of Department of Biochemistry. Now I am going to discuss all the points as mentioned in this slide, that are screening, diagnosis, assessment of glycemic control, and assessment of association of long-term risk. We can perform two types of tests, urine analysis and blood chemistry. By urine analysis, we can estimate urinary glucose, ketone, and degree of microalbuminuria. While by blood chemistry, we can perform blood glucose estimation, oral glucose tolerance test, HbA1c test, lipid profile, serum insulin, C-peptide levels. Now, while collecting blood sample, we should collect blood sample in gray vial as it contains sodium fluoride. As we know, sodium fluoride is inhibitor of enolase enzyme, which prevent glucose degradation due to glycolysis. Whereas in any other vial, due to leukocytosis and bacterial contamination, glucose degradation takes place due to glycolysis at the 7 milligram per deciliter per hour. Laboratory findings. The first is urine glucose. It is a method to detect glycosuria. Two types of tests can be performed, dipstick test and Benedict test. Dipstick test, it is a paper strip impregnated test with glucose oxidase and a chromosome system. In this test, as we can see in the first picture, when we put few drops of urine sample on the test strip, the color changes as according to the amount of glucose present in the urine. Thus, it indicates the exact amount of glucose present in the urine. Whereas in Benedict test, it is a semi-quantitative test. Thereby, it detects any reducing sugar in urine, not specific for glucose, thus not used clinically for diagnosis. The second is urine and blood ketones. Two types of tests can be performed, urine testing and blood testing. Urine testing, it is most widely tested to detect ketones. The most common test is ketodiastics test. In blood testing, we require a special meter strip. The procedure is similar to blood glucose checks. How to use ketone testing strips? First, we completely saturate test end of the strip with urine. Then we shake off excess urine drops. Now wait at least 15 seconds, then compare color on strip to color error on side of bottle. The third test is oral glucose tolerance test. This test evaluates how well the body processes glucose. It aids in diagnosing diabetes and detecting impaired glucose tolerance. In this, we take 5 samples at 30 minutes interval after the first sample taken at 0 minute. As we can see in the given flow graph, which we have taken while we measure blood glucose level after 2 hours of glucose administration, that is, if the value is less than 140 milligram per deciliter, then it is a normal condition. When the value is between 140 to 199 milligram per deciliter, it indicates impaired glucose tolerance, and when the value is greater than or equal to 200 milligram per deciliter, it confirms diabetes. The normal renal threshold value of glucose is 180 milligram per deciliter. Now we commonly use mini glucose tolerance test. In this test, we take the plasma glucose at 0 and 120 minutes after ingestion. Glucose tolerance test, we take blood sample for plasma glucose at 0 and 120 minutes after ingestion of glucose. Diagnostic criteria of OGTT as per WHO. In two conditions, fasting and 2 hours after glucose administration. In fasting condition, the plasma glucose concentration, the value less than 100 milligram per deciliter is considered as normal. The value between 100 to 125 milligram per deciliter indicates impaired glucose tolerance, and the value greater than or equal to 126 milligram per deciliter confirms diabetes. The value after 2 hours of glucose administration, the value less than 140 milligram per deciliter is a normal condition. When the value is between 140 to 199 milligram per deciliter, it indicates impaired glucose tolerance, and when the value is greater than or equal to 200 milligram per deciliter, it confirms diabetes. Now, OGTT in gestational diabetes. As per the DIPSI guidelines, in ANC clinic, a pregnant woman undergoes preliminary examination. She is given anhydrous 75 gram oral glucose dissolved in 300 ml of water over 5 to 10 minutes regardless of time of last meal. Impairment of glucose tolerance develops normally during pregnancy, particularly in second and third trimester. While performing the test, when pregnant woman comes to ANC clinic, testing for GDM at first antenatal visit, we give her 75 gram oral glucose. Then we take the blood sample at 0 and 2 hours after administering the glucose. If the test comes positive, that is, the value is greater than or equal to 140 milligram per deciliter, in this condition, we manage it as gestational diabetes mellitus as per the guidelines. And when the test comes negative, that is the value less than 140 milligram per deciliter, in this condition, we repeat the test at 24 to 28 weeks. Again, if the test comes positive, we manage it as per guidelines, and when it comes negative, we manage as normal ANC. The fourth test is hemoglobin A1C test. As we can see in the given chemical reaction, the glycated hemoglobin is a form of hemoglobin that is chemically non-enzymatically linked to glucose and the N end of the beta gene. When blood glucose levels are high, glucose attached to the hemoglobin in RBC. Therefore, increased glycated hemoglobin reflects the average level of glucose to which the cell has been exposed during its lifespan, that is 90 to 120 days. Here we specifically use purple vial containing EDTA anticoagulant. Interpretation. When the HbA1c value is less than 5.7%, it interpreted as a normal condition. When the value is between 5.7 to 6.4%, it is a pre-diabetic condition. When the value is greater than or equal to 6.5%, it confirms diabetes. Now, when the lifespan and size of RBC gets affected, in that condition, we can't perform HbA1c test as per in sickle cell anemia, pregnancy, particularly in second and third trimester, glucose 6-phosphate dehydrogenase deficiency, hemodialysis, and recent blood loss. Now, recommended frequency of HbA1c. While type 1 diabetes mellitus during minimal or conventional therapy, the recommended frequency is 4 times a year. While in intensified therapy, the recommended frequency is every 2 months. In type 2 diabetes mellitus, when HbA1c level is greater than 7%, the recommended frequency is every 3 months. When the value is less than 7%, the recommended frequency is every 6 months. Now, methods of estimation of HbA1c. High performance liquid chromatography, it is a gold standard method. Borate affinity chromatography, electrophoresis, immunoassay, and colorimetric method. The fifth test is serum fructosamine. This test indicates the degree of glycation of serum proteins, particularly albumin. More useful than HbA1c test as it evaluates the effectiveness of treatment in more immediate time window. This reflects an average blood glucose level over the previous 1 to 3 weeks as lifespan of albumin is about 20 days. The normal range of serum fructosamine is 170 to 285 micromole per liter. We can see in this chart the indications of serum fructosamine. The first is diabetes management, the second is short-term monitoring, the third is monitor impact of diet, and the fourth is diabetes during or after pregnancy. Self-monitoring glucose systems. Capillary blood glucose measurements performed by patients themselves are extremely useful. Meters and the test strips are calibrated over the glucose concentration ranging from 60 mg per deciliter to 160 mg per deciliter, and the accuracy is not as good for higher and lower glucose levels. Educating the patient in correct sampling and measuring procedures will help ensure the accuracy of data obtained by home glucose monitoring. The seventh is the insulin sensitivity and resistance test. This test assesses how the body responds to insulin, crucial for regulating blood sugar levels and diagnosing insulin resistance. A common test is HOMA-IR test. This test used to estimate insulin resistance, evaluate the risk of type 2 diabetes and metabolic disorder. We have shown HOMA-IR calculator. The formula to calculate HOMA-IR is glucose, which is in milligram per deciliter, into insulin in mole international unit milli international unit per liter divided by 405. We have given an example in which the fasting glucose level is 90 mg per deciliter and the fasting insulin level is 12 milli-unit per liter. The value came is 2.67. The interpretation of this test is when the score of 1 indicates normal insulin sensitivity, when the score above 2.9 indicates significant insulin resistance. C-peptide assays. Diagnostic value. C-peptide level indicates insulin production. As we can see in this chart, when the proinsulin gets converted into insulin, the C chain between the A and B chain gets released. Thus signifies the number of C chain released shows the amount of proinsulin got converted into insulin beta cells is a major autoantigen which is source of autoantibodies in type 1 diabetes mellitus. Islet cell cytoplasmic antibodies may be used as a marker for type 1 diabetes mellitus. Now we can also perform screening for diabetes associated complications, example microalbuminuria, dyslipidemia, and thyroid dysfunction, etc. Dyslipidemia. In type 2 diabetes mellitus, distinct diabetic dyslipidemia is characteristic of the insulin resistance syndrome. Thyroid dysfunction. In hyperthyroidism, insulin level drop and blood sugar rises, increasing the risk of diabetes. Microalbuminuria. The microalbumin test detects microalbumin, a type of protein in the urine. It is predictor of microvascular damage. The rate of urine albumin excretion for microalbuminuria is 30 to 300 mg per day. The result of this is when the value less than 30 mg per day is considered normal, and when the value greater than 300 mg per day is microalbuminuria, which may indicate more advanced kidney disease. The method of estimation can be of two types, qualitative and quantitative. Qualitative example, dipstick method. Quantitative example, enzyme-linked immunoassay, immunosorbent assay, radioimmunoassay, immunoturbidometric assay. Now we will conclude our presentation by the diagnostic criteria for diabetes as per the American Diabetes Association are as follows. 4 tests are performed: fasting plasma glucose, oral glucose tolerance test, random plasma glucose test, and glycated hemoglobin assay. The normal plasma glucose value for fasting plasma glucose, if the value is less than 100 mg per deciliter. In pre-diabetes condition, the value will be between 100 to 125 mg per deciliter. And when the value is greater than or equal to 126 mg per deciliter, it confirms diabetes. In oral glucose tolerance test, when the value less than 140 mg per deciliter, it considered as normal condition. When the value between 140 to 199 mg per deciliter, it considered as pre-diabetic condition, and when the value is greater than or equal to 200 mg per deciliter, it confirms diabetes. In random plasma glucose test, when the value is greater than or equal to 200 mg per deciliter with symptoms of diabetes, confirms diabetes. And in the glycated hemoglobin assay, when the value is less than 5.7%, it considered as normal. The value between 5.7 to 6.4% considered as pre-diabetic, and the value greater than or equal to 6.5% confirms diabetes. Thank you.